So I have no financial arrangement related to anything I'm going to talk about today, so nothing to disclose. The topic of the presentation is stages of change and the spirit of motivational interviewing. And I'm going to explain why I think it's so helpful to talk about these two things together. So I'm hoping to cover what is the trans-theoretical model of change, so the stages of change model, and how this is different from MI. It's a standalone model, but how it's extremely helpful for anybody working with individuals wanting to make a health change, including substance use, to be able to assess and then match treatment accordingly. I also want to then talk about a little bit of motivational interviewing and some of the core concepts. So not drilling into how you would apply MI in general, but really how you can understand where this fits into your overall kind of treatment plan, and then go through what is the spirit of MI. So what are those foundational principles that are part of this model that can be applied kind of across settings, across roles. So how can you sort of think about adopting some of these principles with the work that you do, sort of regardless of if you're applying the full intervention or even components of the intervention. So let's start with the stages of change models. So why is it important to understand this model, and then how might you use it? So it's called the trans-theoretical stages of change model. It is an evidence-based model that is not a treatment intervention, but it's actually an assessment tool that allows us to match a person where they're at and what they would need to benefit from treatment. So it's often linked with MI, but it actually was developed separately. It's not connected. It fits very, very well, but you can use the stages of change model to assess where's my patient or my client in terms of their stage of change, and make some informed treatment decisions regardless of what that intervention is going to be. So what is this model in a nutshell? Well, I like this graphic. It's represented in multiple ways, but I like this graphic represented as an upward spiral for a couple of reasons. One is this applies to people making any kind of change. So it isn't just for substance use. It can be applied to if I'm trying to lose weight, or I want to change the food that I'm eating, or I want to exercise more. I want to have more of a spiritual practice, right? So anytime we're looking at making a change in our life, we likely will enter this process. And where a person enters isn't always starting at the beginning in pre-contemplation and working in a nice orderly fashion. That people will actually enter this model at different points. And so it's important to understand, what do each of these stages mean? They may also kind of go in and out. So you can see relapse is included. It is actually the rule and not the exception that people will slip back into their prior behaviors. And that's a normal part of the change process. So we're not trying to avoid relapse. We're trying to teach people and have them be prepared for, if they slip back into those old behaviors, it's just falling into that preset pattern, that habit, and that they can get back out of it quickly, and they don't have to start over at pre-contemplation. They can go right back into action. And that oftentimes when we're talking about changing a substantial habit, like people that have a substance use disorder, that is a hardwired set of behaviors. If we're going to change that, that people will oftentimes have to move through this cycle multiple times, but they don't forget what they learned in prior iterations. So it really builds on itself. So I like to think about this as like moving up a spiral staircase. They're not stepping backwards. They just may be turning the corner and, oh, here I am back at a slip. Okay, so I'm going to turn the corner, take one more step, turn the corner again. And because of everything I've learned, I can start right back at preparation or action, or maybe even just flip into my maintenance pattern, whatever that might be. So really encouraging people that they don't start over at the ground floor, they don't start from zero, but that moving through this process as many times as it takes is just the process of change itself. So it's really helpful to understand each one of these categories so that you can identify, where is my client at right now, where do they want to go, and how do I help them move through as they kind of go through this cycle. So pre-contemplation, again, recognizing that this isn't necessarily linear, but identifying somebody that if finds himself in pre-contemplation, that just means that they're not considering a change in the foreseeable future. Doesn't mean that they're in denial. That concept doesn't really hold water, but that they're just not at a point where they have ambivalence, where they want to make a change, where they have the kinds of things set up in their life to be able to make that change. So pre-contemplation just means they're not going to be doing anything different anytime soon. Contemplation means that I'm now thinking about making the change, and I may have values or motivations around that, but I also have part of my some barriers. Maybe I don't feel as confident about making that change. Maybe I need some additional resources or support, or I've just never done it before, but I'm considering doing it, right? I haven't put together a plan. I haven't taken any steps, but I have some ambivalence on board, and I'm going to talk more about ambivalence here in a second. Preparation is where I'm actually starting to plan that change out. So what are the steps that are going to happen in the immediate future, not next year, but tomorrow, over the next week. And then action means that I've not just starting making that change, but I've actually done those change behaviors. So I've implemented the plan that I constructed in preparation, and that those behaviors have actually shifted. So they're now behind me. So I'm in the active process of different behaviors. And then maintenance means that I'm doing those change behaviors, and I'm maintaining them. So that's where we're starting to see the habit is getting replaced, and a new habit is being implemented on an ongoing basis. So how does this help us to understand where a patient might be? Well, the best thing is it helps us to then link, what do I do with a person who's in one of these stages? So for folks that are in pre-contemplation, and I think that this is important, we can use some components of motivational interviewing, but MI and ME are actually not the best intervention for people that are at this place, because typically if they're in pre-contemplation, they don't have a lot of ambivalence. So what we want to focus on here is really just making sure that we have a strong alliance, that we've built rapport. And if we're using any aspect of MI, it's likely what's called the decisional balance, which is a fancy a term for kind of a pros and cons list. So what are the pros of making the change? What are the pros of not making the change? What are the cons of staying the same? What are the cons of making a change, right? So comparing those things is called a decisional balance. And what that can do is actually create ambivalence where maybe there wasn't any to begin with. But we don't want to go hard at trying to capitalize on motivation because we may actually, kind of rupture the rapport. That's not where people are at. So if we recognize somebody's in pre-contemplation, they're not considering making a change to their behavior, then we want to do what's called coming alongside them and really just focusing on, okay, what do you want to do? What is important to you right now? And having sort of that non-judgmental approach to ensuring the alliance, ensuring the rapport. Now, once somebody gets into contemplation, that's where MI strategies and techniques really, really shine. So that's the zone where we want to be applying, capitalizing on their motivation and helping them to really start to move through that process. Now, in terms of if I'm in a clinical role with someone, by the time they get to preparation, they oftentimes don't need me as much because people can come up with a plan that's going to work for them fairly easily. What we can help them with in the planning process is making sure that they're doing this in a way that's measurable, that's actually attainable. So working through things like developing SMART goals is one thing that can be very helpful in preparation. And then when they move into action, that's where we're really wanting to reinforce their self-efficacy that they can do this. So that's where relapse prevention strategies can fit in. And then the same thing with maintenance. What we're trying to do there is help them to think through, what are my high risk situations that are coming up? What are the things that are going to become roadblocks or possibly trigger me into a slip? And how do I really build those relapse prevention skills to make sure that if I do have a slip, I can come out of it very quickly, or even get to the point where I'm preventing slips in general. So again, with pre-contemplation, what we're really trying to help somebody go through is build that ambivalence. So really be thoughtful about what are their current behaviors doing for them, because they're doing something, and then what are their current behaviors not doing for them. So kind of bringing awareness to that problem and keeping them engaged in treatment, keeping them engaged in the process. So really seeking to listen, to gather information or elicit information about past experiences, past successes. What are the strengths that they have that they could capitalize? What are their value sets? Like, what's important to them? And then just making sure that regardless of the behaviors that they're engaging in, that we're conveying that non-judgmental, empathic, caring attitude, right? Because when we convey genuine acceptance of what they're doing, then we're not setting them up to disengage from that relationship. So that's our focus in pre-contemplation. With contemplation, this is where we can start to apply some of those MI techniques. So we're really just wanting to keep them talking about change and not starting to talk about why they don't want to make the change, but really reinforcing and highlighting and reflecting when they talk about why they want to do something different. Boosting their awareness of what they can do, right? So oftentimes people don't make a change because they lack confidence in their ability to do it, not because they don't want to do it. So really looking for opportunities to boost that confidence, and then increasing that sense that there is benefit to the change that they're going to make. So there's a couple techniques that we can use here, like developing that discrepancy. So reflecting back any ambivalence that they might have, really exploring their value set and their goals and how the change behaviors in the service of those things. And then addressing any discord that may arise between part of me really wants to make this change and part of me doesn't. So we can talk about that. And one of the easiest techniques to sort of have that dialogue is to shift our language from using things like, you want to make this change, but you also don't want to you want to make this change and there's part of you that is scared, or there's part of you that doesn't feel like you're going to be successful at it, right? So even just replacing that word but with and is a really a quick reframe to help people kind of hold space in their mind that both of these things can exist at the same time, and that's actually the normal state of being in contemplation. And then looking for ways to really support their self-efficacy. So helping them to have optimism and affirm that commitment to making the change and really start to move into planning. Now, once somebody gets to the action stage, our goals are really just to kind of step back and help to monitor progress, reduce any barriers that might be there, have active discussions about that, and then help them to not go too fast too quickly, right? So really using that SMART goal concept in planning so that when they get to action, they're doing things that are manageable and attainable and celebrating those little successes. Now, we talked about relapse. I think it's just important to highlight that this is part of the stages of change model. It doesn't sit outside of it. It's a normal occurrence in any recovery process or any change process, and that we want to be educating people this is not a failure. We want to be trying to avoid the abstinence violation effect, which is the cognitive effect of feeling so guilty and so ashamed that they've returned to those previous habits that they kind of like, screw it, I'm just gonna keep doing it. And that's when like a binge pattern can form. So we want to avoid that and really have them see it as, okay, that happened. Let's look at this as part of the bigger picture. This is a normal thing that occurs. Let's identify what were some of the warning signs. What did you do? What didn't you do? What could you do differently next time? So really see this as an opportunity for them to re-engage in the change process and identify new learning. What could they actually take away from this experience and to avoid becoming discouraged? So that's the stages of change piece. Now let's move into the spirit of MI and where does this fit in? So I think that it's important just in general to understand that what motivational interviewing is trying to get at is really, I think, encompassed by this quote from 1660 that even back then we understood people are generally better persuaded by the reasons which they have themselves discovered than by those which have come to the mind of others. So MI in a nutshell, all of the techniques, all of the foundational components of the model is to be able to work with people in a way that helps them to understand why they're doing it, what they want to do, and to move forward with that action plan for themselves that we're not telling and we're not doing for them. So it really is a different way of interacting with the change process. So it's a style of communication, talking with patients about change rather than trying to educate or skill build or some of the other techniques or interventions that we use in our toolkit. So MI is very much a collaborative, person-centered form of like they call it guiding or dancing with the person, where we're trying to just elicit what's already there, that they already have what they need to do this. And then our job is just to have a conversation in a way that capitalizes on that part of them that wants to make the change and their reasons why. So it's really being able to talk through how they're going to benefit from this, and also to talk through, accept, and process what maybe they're reluctant about, what they're ambivalent about, the part of them that is scared or concerned or confused, right? There is a ton of research that supports MI for all types of change behaviors, not just substance use. So if you're interested, there's so many studies and meta-analytic studies that have reviewed MI as being very effective for helping people to move through this process of change. So I wanted to talk specifically in this echo because we don't have a lot of time and because this isn't really geared to help teach or train you on the intervention pieces with MI, but to understand that the spirit of MI is really just appreciating ambivalence as part of the change process, that it is it's a necessary piece of how we get to the place to actually change a habit. And so if we don't appreciate that, respect that, and call that ambivalence forward, we could be missing a huge piece of this process. So what is ambivalence? It means simply to be of two minds. So there's part of me that feels very motivated and has all clear reasons why I want to change my behaviors. And then there's part of me that is scared, that doesn't want to, that actually likes or is getting something from the status quo. It is not a lack of motivation. And so we have to be careful that we're not labeling somebody who's experiencing ambivalence as lacking motivation, that they don't want to do it, because that isn't the case, that in fact, both sides are present. And so we want to be acknowledging both of those sides and then shifting our alignment towards the side that wants to make the change and helping them shift that alignment and boost their confidence in the ability to be successful in making that change. So this appreciation of ambivalence is just recognizing it's a normal part of the change process, and that it happens 100% of the time before somebody actually moves into action, into doing something differently. So how do we appreciate this ambivalence? Well, the first thing we need to do that's part of this spirit of MI is to avoid what's called the communication trap. So that's where we start to argue why they should do this change, where we're actually arguing one side. What's going to happen automatically is they're going to start to defend the status quo. And if you can even see this happen inside their own minds when you hear patients say, well, I know I should make that change, or I know I have to make that change. So I'll often ask them to pause and say, okay, now what do you feel when you say that to yourself? And typically, like, I really don't want to do it, right? Because they've already come up with their defense of why they shouldn't. So when we engage in that communication trap, we actually decrease their motivation significantly, and we can send them back to pre-contemplation. Now, one of the ways that we engage in that communication trap is called the righting reflex. So that is our natural inclination to help. We want to make it better for them. We want to fix it, right? But what that does, because we know that people are better motivated by the reasons that they have, is is we start to tell them what they should do, how they should do it, that they just need more education, more knowledge, they need to understand it, and that's going to motivate them. But all we're really doing is creating resistance and moving them away from what they themselves might actually be motivated. So we're engaging in this writing reflex because we think, they don't see the problem, they're in denial, they don't know what the problem is, or they don't know the consequences, they don't know how to make the change, or they just don't care. They don't care about themselves. They don't care about making that change. So we shift into the writing reflex because we're like, we need to build that insight, we need to give them insight, we need to give them knowledge, or we need to give them skills. And unfortunately, when people are in a contemplation stage, not saying that insight, knowledge, and skills are not valuable. They're very valuable, particularly in action and maintenance. But in contemplation, that's not what people need. So when we engage in the writing reflex, we just collide with that ambivalence. So it essentially looks like a tug of war, right? That we're now pushing against the part of them that doesn't want to make the change and strengthening that muscle, which is the opposite of what we want. So what typically happens is patients may make the change briefly. They may try to satisfy us or the part of them that does want to do it, but it's not going to stick. It's not going to continue. And very soon or very quickly, they're going to revert back to the old behaviors. They may listen politely and then just go out and do what they were going to do anyways. They may actually protest. And so we know that we've engaged in the writing reflex when we start to actively argue or we sense that that tension where it really feels like a tug of war. But at the end of the day, no one benefits. And unfortunately, we have a tendency as treating providers to sort of blame the patient and say, well, they're just not motivated. They're just not ready. Versus what I think is happening in reality is that we've started to engage with someone who's in contemplation who, and we're having a mismatch with the intervention that we're providing, trying to give them things when actually we just need to align with the spirit that I'm going to talk about. So I would say we want to apply the rule with people that are in the contemplation stage of change. We want to do everything we can to resist the writing reflex, understand what their motivations are, both for ourselves, but also to bring that into the room so they clearly understand their motivations. We seek to listen, so we should be listening more and talking less. And we look for opportunities to actually empower them so that they feel that they have the confidence and the ability to act on the change that they would like to make. So that's why the spirit can be applied to any patients that are in, I think in any stage, but particularly that are in contemplation, because the spirit is the foundation of this model. So the principles, processes, the skills and techniques, they all sit on top of that spirit. So you don't have to do the above if that's not your role or that's not the training that you have, but all of us can apply the spirit to the clients that we work with. So what is the spirit? It means that we are doing unconditional acceptance, that we are practicing collaboration, and that we are practicing evocation. So what does that mean? So with acceptance, that means that we're conveying in our in that alliance, in that conversation, that they have absolute worth regardless of what they choose to do, right? Everything is a choice, but we see them as having worth regardless of what they do or don't do, what they put in their bodies or don't put in their bodies, and that we are going to interact with them with respect and trust. This amazing thing happens, and they've done this with numerous studies, that when people experience this acceptance alone, nothing else, that they themselves will then start to act in the direction of positive behavior change, that they essentially are freed from that tug of war, and they're able to go, actually, I do want to do this for myself. So we don't have to convince anybody. If we can convey acceptance, they will naturally move in that direction. Now, part of acceptance means conveying accurate empathy, which means that we actually do a lot of work to listen and try to elicit their perspective on things. What are their values through their eyes, and that we support their agency, that regardless of use or amount of use or frequency of use, that they have the freedom to make choices, that everything is a choice, that they have the freedom and the right to their own attitudes, their behaviors, their perspective, and that it's just as valid as anyone else's, and that we can affirm all of those strengths and the efforts that they're making even if it's just having that conversation. It doesn't require them doing something to get affirmation. So when we're practicing acceptance, we're moving away from an authority perspective where we're telling them what to do, where we're assuming that they don't know how to make these decisions, that they need to be instructed, and we're moving towards that sort of really highlighting that they have the ability to self-direct, to make an informed choice, and regardless of their use behavior, that they can make rational, informed decisions. Collaboration is the next part of the spirit, and that's where we're really working to engage with them, assuming that they are the expert and that they are the ones making the choices in their life. So it's compared to the experience of dancing, right? That we're doing it with them, but we're not wrestling them, we're not forcing them, coercing them, persuading them. And that all of the things that we're talking about are done with the person in the pursuit of what's important to them, not our values. So part of collaboration is recognizing that they are the undisputed expert on themselves, and that people typically know what they need to make the change and why they need to do it. Our role is just to bring that into the room. So when we're doing collaboration, we're moving from a confrontation standpoint where we're trying to impose some value or some reality about the consequences of their use or the consequences of their behaviors, to more of a collaborative stance where we're really trying to honor their experience, their perspective. What is this doing for you? How is this actually working in your life? I genuinely want to understand. I'm not going to judge that. So that's more of a collaboration standpoint. And then lastly, evocation. I think this is one of the most important things, is recognizing that they already have what they need to bring that change forth, versus thinking that it's a skills deficit or a motivation deficit. They may need some assistance with some tangible skills down the road when they move into action or maintenance, but when they're in contemplation, we're absolutely recognizing that they have everything within them, that they don't have to wait until they're ready. We don't have to wait until this sort of nebulous concept of being ready happens. But we can just have a conversation to evoke what are their motivations and strengthen that. What is their why? And help them to really be in alignment with the decisions that they're making and how those inform their why. Are they doing that in the service of that value, or are they actually acting in opposite? And why might that be happening? So seeking to understand that perspective. So this is moving from an education approach where we're trying to address deficits by giving them education or knowledge or skills, to more of an enhancement of that intrinsic motivation to change. What are their perceptions, their goals, their values? So in essence, the spirit of MI is engaging with patients in a way that moves us out of this wrestling encounter where we're trying to get them to do something or give them something, to more of a dance where we're really collaborating with them, moving in concert with them, and that they're actually leading, right? We're doing the following. So that is all I have on this topic today. Were there any questions or comments that people wanted to talk about before we move to a case?